I would like to introduce our next speaker, who is Dr. Eric Topol. We are so pleased to have him with us here today. He is the founder and director of the Scripps Research Translational Institute, and he's a professor of molecular medicine and executive vice president of Scripps Research. He is one of the top 10 most cited researchers in medicine. He's been elected to the National Academy of Medicine. He's been voted as the #1 most influential physician leader in the US in a poll conducted by Modern Healthcare. He's also the principal investigator of numerous grants from the National Institutes of Health in the US, including a more than $200 million grant to lead a significant part of the All of Us Precision Medicine initiative in the US. He was recently commissioned by the UK in 2018-2019 to lead planning for how the National Health Service in the UK will integrate AI and other new technologies into its practice. He has published 3 bestseller books on the future of medicine, including The Creative Destruction of Medicine, The Patient Will See You Now, and most relevant to our work today, Deep Medicine, How Artificial Intelligence Can Make Healthcare Human Again. Many of you know him through social media with his educational tweets, interpreting the latest science with the trademark article screenshots with yellow highlights on the key passages. He also, together with our own Pranav Rajprakash, is one of the founders of Dr. Penguin, helping researchers keep up with the cutting edge of AI in healthcare research. He is a great friend of the AIMI Center, and so we're especially delighted that he can be here today to kick off our symposium. Eric, welcome and thank you. The floor is yours.
Oh, Kurt, thank you. It's great to be with you on your inaugural symposium. And let me just congratulate you on not just this, but the whole AIMI program that you developed at Stanford. It's a model for the country as we try to move forward in the AI medicine era. So I'm going to try to quickly get through what is the future of AI in medicine. And it's a challenging thing because, of course, there's a lot there. The first thing I wanted to point out is we need help. We talk about precision medicine, but that's only a small part of the story. We need accurate medicine. We're far from it. In fact, the problem we have is medical errors are profoundly common. There's over 12 million serious ones per year. And of course, there's lots of waste and the cost and all the other problems that are related to a lot of these diagnostic errors, which AI can make a big difference. Now, one way to go about this, which was done at Stanford, is to go very advanced. That is the smart toilet with all these different features, actually just extraordinary. And what's interesting is the founder of convolutional nets, Jan LeCun, he wrote, "This is going down the toilet for the good of humanity," literally. But that won't fix our medical error problem. So it's a good thing that that's being pursued. And I think that's going to someday take us to some new heights of future of AI in medicine. But what we're stuck with today is a much more realistic challenge. I want to take us through 3 areas: the doctor and clinician story, the patient side, which doesn't get enough respect as far as the future of AI in medicine, what patients can do, and then the humanism part. So as you've already touched on, Kurt, in your introductory remarks, we're really good at using AI to find things that experts, radiologists can't see, such as in a chest x-ray, finding a tumor nodule that was missed, has been shown by many convolutional neural network studies, or mammography, to make it a interpretation that's far more accurate. This is the NYU study. It's I think the most impressive mammography study to date. And that's an area where there's serious problems of false positives and even false negatives. So this is really important stuff. Now, perhaps the best way to introduce what machines can see, be trained to see, if you will, that humans can, is the retina. Because the retina, if you show this picture to retinal authorities and you ask them, is this from a man or a woman, the chance of them getting it right is 50%. But interestingly, an AI algorithm can be trained to be 97, 98% accurate. So first thing I wanted to do is just review what machines can see in the retina. Who would have guessed this when you train with hundreds of thousands, if not millions of images? So recently, kidney disease, that is tracking chronic kidney disease. I mean, who would have thought that? Diabetes and blood pressure control, Alzheimer's disease, a big project by Pierce Keene and his colleagues at Moorfields. Predicting the course and intervention for macular degeneration, which is really important because it's a leading cause of blindness, and it's not something that you could predict with ophthalmologist's eyes, but you can do far better with algorithms. Now, the cardiogram is my favorite pattern to review. I've been doing it for a few decades, I'm afraid to admit. And I would never know if it's a man or a woman or the age of the patient. But of course, you can train algorithms to know that pretty darn well. No less their heart function, whether they have anemia and the extent of it, and then to make difficult diagnoses like amyloidosis or pulmonary hypertension very accurately. This one is taking it perhaps a little bit too far. This recent study was about predicting when you would die from your cardiogram. I'm not sure that has especially clinical value. You know, the things we want to keep our initiative and work on are things that can make a real difference in the clinic. It isn't just the cardiograms of the retina, it's pathology slides. And so here you can see that if you take, this was just published and it's pretty extraordinary just a week ago. If you take slides, whole slide imaging, and you train them, train a neural network to interpret them, you can get to not just structural changes like copy number variants, amplifications, deletions, what are the driver mutations, what is the prognosis of the patients, what is the tumor, if it's normal or tumor on the slide, and even the origin in the body. It's pretty extraordinary. This was on 17,000 approximate slides and over 10,000 patients, just published in Nature Cancer. And it's not the only study. This was just published yesterday. And this is a study of using deep learning for predicting the transcriptome, RNA-seq in tumors. And this heat map is basically giving the probability of what is the transcriptome signature. So it's really extraordinary. These are things that humanized pathologists can't see. And in fact, oftentimes pathologists can't even agree on the slide interpretation. So this is a big boost. And it's also seen in the clinic in this prospective trial, one of a limited number of prospective trials, where at brain biopsy, instead of having to wait for 30 minutes for a frozen section to be interpreted, this can be done in seconds, that is in 2.5 minutes. And that's pretty darn impressive work that you all participated in this Nature Medicine report earlier this year. Now, cancer is ideal for the AI in medicine future because there's so many levels of data, not just the clinical data, the genome of the tumor, the patient, circulating tumor DNA, methylation, the scans, the pathology, for organized the digital infrastructure. We'll talk about so much data to find in each individual the best intervention. And the AI in cancer is really broad, not just the drug discovery side, but matching patients, the right dose, the right combinations. These are real important mathematical challenges that can be addressed with deep learning models. And one of the exciting things is out of Japan, the ability to, in real-time imaging, machine vision, to determine whether there's polyps that are being missed by the endoscopist, and also whether the likelihood of that tumor is cancerous. That is, does it need a biopsy or not? And that's just now getting into prospective trials, but just the capability of doing this is pretty impressive. So a little glimpse into the future there. So I don't want to go through all the different specialties, but just to give you a flavor, this is going to affect in the future every medical discipline. There is no exception here. And so, and it's not just those that are in the hospital, it's paramedics, it's all the paraprofessionals, pharmacists, the works. And it's also across the health span. Everything from embryo selection, which has not changed for decades, is very imprecise. Now that's getting improved, all the way to trying to understand a patient's prognosis at the moment they come to the hospital. And that's especially important in the COVID-19 era. But it's not just about that, about the patient side. It's also making the imaging better. This is a Stanford spin-out company, Subtle, and you're familiar with it, but it's really interesting how it can get scans, MRIs much more quickly, and be able to upgrade the resolution. So you could get away with a much lower resolution scanner and get much more crisp images. And I'm really into images too. And my favorite tool is the smartphone ultrasound. It's amazing. You get such high quality images through a probe connected to a smartphone. And there are several of these now that are FDA cleared. This is the heart. I haven't used a stethoscope in now a decade. Why would you do that when you can see everything in seconds? Everything about the heart. All of its structures, the size of the cavities, the strength of the muscle contraction, and you can track the color flow of the blood. That is there a leak of the valve, how extensive that is, all in seconds. And you can show it to the patient, which they never really would get that real-time experience with a sonographer. So I'm so enamored by this. I did a total body selfie, medical selfie, in every part of my body, from the carotid, sinuses, thyroid, all the way through the liver, kidney, gallbladder, iliac artery, spleen, aorta, and inferior vena cava down to my left foot. Now, you can do that, or soon we'll be able to do that. That is part of the AI medicine future. One is really exciting is that now algorithms are being developed by multiple companies, where it basically can direct anyone with no ultrasound experience to be able to have the image just tilt slowly, turn it clockwise, move it up or down, and it auto captures the image, auto labels the image, and starts to get even the automatic interpretation. That's pretty extraordinary. So you'll see medical selfies in the future someday, but well before that, we'll see clinicians doing ultrasounds, not just of the heart, but anywhere in the body with AI guidance. Pretty exciting stuff. Now for the downside, we don't have much high quality research in the field. In fact, Kurt reviewed some of the absolute best work that's been done to date. This is really the list of prospective studies, not too many of them. And they're only in a limited number of disciplines so far. And more rigorous would be the randomized trials. And you can see there's only 7 of them. And 6 of them were performed in China. Only 1 outside of China to date. We've got to do much better of doing randomized trials. The US and the UK have prided themselves on randomized trials, and they don't even show up yet on this list. Now, Kai-Fu Lee, who's one of the real AI leaders, and I wrote a paper last year in Nature Biotech about It Takes a Planet. And what we talked about is, why don't we have a planetary health system and use nearest neighbor analysis? That is, if we had all the data of all the billions of people on the planet in one resource to have digital twin infrastructure, we could use and learn from each person to find their most closely associated by all criteria and treatments and outcomes that worked, which would be much more specific and complementary to clinical trials. We couldn't do that if we didn't have federated AI. That is, the ability to keep the data at its source, at its venue, and not to move it anywhere, but the algorithm comes to the place, to the data set. And homomorphic encryption. The idea of a planetary learning health system with AI would be unthinkable without these features. So that's really important. We now have capabilities were not even thought of in recent months. So this statement, which there's been variants of it also coming from your colleagues at Stanford, machines will not replace physicians, but physicians using AI will soon replace those not using it that really kind of sums it up. This is going to be an integral part of the AI in medicine future. And I also want to just briefly mention that it's not just medicine, it's life science. And if you look at how it's transforming science, it's just remarkable. So the imaging that we've been talking about is macro, but what about going on at the cellular, subcellular level, the machine vision, the genomics, the protein structure, the drug discovery? It's just extraordinary. And it's also playing out in the COVID-19 pandemic as well. Now let's turn to patients because, as I say, they don't get enough priority in terms of AI in medicine, but they're going to have a big impact because algorithms can be given to patients with their data that they're generating through sensors, through their smartphone, and through other means, and that can be a great part of the future. The first one that was cleared by the FDA was for diagnosis of atrial fibrillation, and that's now almost 3 years ago. And first it was AliveCor, then Apple. And the ability to diagnose atrial fibrillation on a smartwatch is pretty extraordinary if it's using the right people. The problem, of course, is a lot of people are doing checks on their heart rhythm, and there are people that wouldn't have any chance or very remote chance of having any sort of significant arrhythmia. But that's going to get much more extensive. The idea you could get potassium for people with kidney disease through the watch, or you could detect low glucose through the cardiogram, or you could detect seizures before they happen. These are things that will be in the patient's domain. But even beyond that, every single common, non-serious, non-life-threatening diagnosis, one by one, is getting approached by AI. Here is urinary tract infections. If you're in the UK, you can go to the pharmacy and get an AI kit to give accurate diagnosis of your UTI and also get a prescription. Not in the US so far, but at least 3 or 4 of these have been cleared by FDA to move forward. And the idea is that with machine learning, you can not just make the diagnosis, but even get the best treatment, the best antibiotic. So that's going to be something that's going to be handed off to patients in the times ahead, as is diagnosis of ear infections in children. There's no reason, one of the most common reasons to go to a pediatrician, that this can't be done through the parents and the cloud algorithm with a deep learning model. And then there's skin lesions. You already touched on that, Kurt, as far as basal cell, but these are so common, and rashes, all sorts of skin problems. And now we have data that's pretty remarkable about being able to diagnose all these things pretty accurately, at least retrospectively, compared to a limited number of dermatologists, primary care doctors, and nurse practitioners. And so the idea that you could look in the mirror and get the diagnosis is not so far-fetched. It's something that is a bit concerning about picking up all sorts of things and false alarms, but it's certainly something to be thinking about as we move forward. And then this study is pretty amazing. The Snellen test for eye acuity, vision acuity, was developed from 1862. And it was Stanford, of course, it seems to be often Stanford, that has come up with the acuity test to put this into the patient domain in the future, being able to get a good smartphone or tablet eye acuity test. Pretty practical, darn important stuff. Now, one of the other things that's not getting enough respect by the medical profession is the diet and how AI can influence better diet choices and guidance for patients. And we know that if you look at the same diet, food, and the same amount, the exact same time, the same order, you get markedly different heterogeneous triglycerides and glucose and insulin levels, even in identical twins, in 1,000 identical twins. And so that's why I've been keen about what diet can be influenced by guidance to make for healthier diets, to avoid glucose spikes, which are much more common than we had ever envisioned in healthy non-diabetic people who are monitoring their glucose with a continuous sensor. And that is influenced by the gut microbiome. In this study that just came out recently in Nature Medicine, that was a study of Tim Spector and his group in the UK. And they showed how important not just the microbiome is, but the order of food for triglycerides, for glucose, for C-peptide, insulin, a marker. And it was in over 1,000 twins. I mean, it's pretty impressive study. There was a main cohort in the UK and then a validation cohort of 100 people in the US. So you'll be seeing more of that in the future, as you will be seeing the quantification, digitization of the state of mind, which will be important for helping people with depression and anxiety to deal with the problem. We don't have enough medical professionals to support the big burden of depression and mental health conditions. That's in the early phases, but it's an exciting area. So just to sum up this portion is that when you combine hybrid models, deep learning models, convolutional nets, and various different models, you can get to a point where we will have a virtual medical assistant, taking in all this data, and for those who are interested, to provide feedback and guidance to the person, as well as that data, of course, can be shared with a clinician. Now, the humanism. That's where AI needs to really have its long-term target. That's the most overreaching, important objective. We have a global epidemic of burnout, which has only been exacerbated by COVID-19. And medicine for years has gone to an erosion of the patient-doctor relationship, inadequate time with patients. And so this cartoon by one of my favorite cartoonists, Dave Coverley, feel kind of rushed. That's the typical encounter with a doctor or a nurse in a clinic today. And so we don't want this. The robot will see you now. And this picture of the robot seeing a patient. We want to have the human connection restored to go back to the way it used to be decades ago. What we have right now is physician time spending on electronic records and being data clerks is absolutely preposterous. And we can fix this. And AI is critical to that fix. We have just an incredible number of physicians studied here where most of the time was not seeing patients, but rather serving as data clerks. So this is the way it is in medicine today. And that's not just bad for clinicians, bad for patients, because we want to restore the humanistic side, the critical component of what is medicine. And so instead of this scenario, where the patient who waited 3 weeks to get an appointment is so disenchanted, the doctor isn't even looking at the patient, but rather typing away. We've got to fix this quickly. And fortunately, there are many different companies, large and small, that are into synthetic notes from the conversation that are far better notes than what we have with the current health IT systems. And that's exciting. We need that as quickly as possible. When I worked in the UK review of the NHS with Hugh Harvey, who you'll hear from later in the conference, I learned a lot. But one of the things we learned from the multidisciplinary panel, the economists showed that if we just save 1 minute of data clerk function, the amount of sparing that has on doctors and what it can bring back to patients and patient care is just exponential and extraordinary. So there is no algorithm for empathy, but there's a profound lack of empathy in medicine today. That's what we should be working on with AI in medicine. And instead of all these signs that we see on billboards advertising health systems in the US, like these, the one we really want is the gift of time to patients, doctors, and all clinicians. And hopefully we'll get there someday. So in the words of Francis Peabody, who my close friend and colleague at Stanford, Abraham Verghese, always reminds me of, and that is this paper from 1927. And it's a 6-page paper in JAMA. And the last part of it is about this. The essential qualities of the clinician is interest in humanity. For the secret of the care of the patient is in caring for the patient. We want to do that, but we've been prevented from doing that, and we need to get that back. So let me just thank all the great people that I get a chance to work with every day, these days primarily remotely, but also our funding sources. And Kurt, thanks so much for having me as part of the program.
Thank you so much, Eric, for that really visionary talk. I'm really excited now that we're going to be having Dr. Daphne Koller joining Eric for a fireside chat. Dr. Koller is the CEO and founder of insitro, a company applying machine learning to drug development. And Daphne was a computer science professor at Stanford, co-founder and co-CEO of Coursera, and chief computing officer of Calico. Daphne was one of Time Magazine's 100 most influential people and is a MacArthur Fellow, a member of the National Academy of Engineering, and a Fellow of the American Academy of Arts and Sciences and the International Society of Computational Biology. And the chat will be moderated by Dr. Bhavik Patel and Sharon Zhou. Bhavik is an assistant professor of radiology, director of clinical trials and body CT at Stanford University, and associate director of AI implementation. And his research interest focuses on using artificial intelligence for risk prediction and upstream imaging tasks. And Sharon is a CS PhD student advised by Andrew Ng, whose work spans the theoretical in AI to the applied in medicine, climate, and social good more broadly. And she likes humans more than AI, though GANs occupy a special place in her heart. Welcome, Daphne, Bhavik, and Sharon.
Thank you so much, Eric and Daphne, for joining us today for the Fireside Chat. The topic of our session is the future of clinical machine intelligence, a multidisciplinary discussion. So on that note, it seems that the current state of AI medicine and life sciences is an emerging intersection, but it's still siloed with computational scientists in one camp and doctors or life scientists in another camp. How do both of you see these teams cross-communicate? And how do you foster that interaction and communication, and as a result, effective collaboration between the groups?
Eric, would you like to start?
No, I think you should, Daphne. It'd be great if you would start. Okay. For enough for me already.
We've never enough from you, Eric. It was a fascinating talk, and thank you for that. It's very much a challenge. The current training that we give people in these two different disciplines are almost designed to make them as far from each other as possible in terms of the extent to which we take people who are more from an engineering mindset and convey to them the excitement of doing life science work, and conversely, the extent to which we provide data science tools to the people who are trained in the life sciences. I think that's improving in our educational system, but there is certainly a very long way to go before we really create that kind of vocabulary. So it's a challenge for an organization that really wants to build what I think is absolutely required for success, which is a cross-functional team where people really approach the challenges that we face as equal partners. In a lot of organizations, there is a very significant skew towards one direction or another. You can find a lot of, in my space, biopharma companies that are really very much led from a strategic perspective by the life science groups, and the technology people are kind of like almost a service organization, kind of lumped together with the IT people. And you can find similarly a lot of engineering focused organizations that have a few doctors as consultants or a biologist on staff, but really very much an engineering mindset. Creating that type of organization where the two groups come in and really genuinely lead together, thinking at the same time what the technology can accomplish at the same time that we understand what it should accomplish, is a really, I think, significant challenge, and requires hiring people who come in with that mindset of working together as a collaborative team, and being really open and willing to hear perspectives of others, even if they're very different from your own. And I think many of those also benefit from having at least some number of people that I think of as bilingual, that can really translate across the gap and speak intelligently on both sides, so that you actually have someone who can translate across that spectrum, a very broad set of skills and disciplines. So there's more I can say on this, but I'd love to hear what Eric has to say.
Well, you said it well. I like the bilingual, Daphne. That's perfect. I think we need more integration, and it's certainly possible. I mean, some of it is going on at Stanford. You could see some of the people that are, really basic scientists working with the clinicians in this AIMI that Kurt reviewed. I think that's the ideal scenario, and it's achievable, but it has to have the will, it has to have the resources, the commitment, but I think it's vital, really.
I think there is a lot of work that we need to do on encouraging our educational institutions to create programs that really train those bilingual people. When I was still on the faculty at Stanford, I set up together with my former colleague, Russ Altman, a major called Biomedical Computation. And it was really trying to sort of train people in that way. And I think we trained some remarkable individuals in those early days. And I'm seeing more and more such programs emerging. And I think as we train more young people in being able to communicate across this, frankly, chasm, I think we will be much better off in creating what is, I think, a next generation of scientific endeavor.
Absolutely.
And for students, listen up.
Eric and Daphne, thank you for those comments. I want to remind everybody that's listening that we'll try to answer any questions that are posted. But as a follow-up to that, as you mentioned, we need to try to make some of the tools as widely accessible as possible. And on the other hand, we've also all agreed that we need to try to democratize data as much as possible. And so, Eric, you mentioned the planetary AI. So how do we start to get to a point where we can get data in the hands of as many people as possible? And Daphne, same question for you, because we know that folks all around the world should be attacking these complex issues so that we can all collectively work towards improving patient outcomes.
Yeah, no, I think it's really vital for that because, so for example, we tend to miss out on the diverse people. So a lot of the work that's been done in medicine to date in AI is just the way genomics got started. It's mainly on European ancestry, and extrapolations are made to other ancestries that are not really well rooted. If we had a planetary system and numbers are big and depth of data as well as long data, we could do so much better. When you think about it, we rely on these clinical trials where, at best, maybe 1 out of 10 people might benefit from the treatment at best, right? Overall. And you actually could have pinpoint precision, not just on ancestry, but on every feature. And so we already are seeing that with cancer. There's a infrastructure being built now, which has, I think, about 100,000 people with all the layers that I mentioned. So it can tell the next person that comes along what would be for the nearest neighbor, twin or twins would be the best treatment outcome. Now, that isn't necessarily looked at alone. That's looked at with the clinical trials and integrated with all the other information. But that's what we should be working on. Now, when I proposed that with Kai-Fu Lee, we worked together on writing that up. That was pre-pandemic, and there were still strained relations between China and the US, but they're a little more strained these days. But the point is that everyone on the planet should have the same interest and should put aside any economic and other issues, because we all work together, and we couldn't think about it, as I mentioned, if it wasn't such a thing as, the encryption tools and the federated AI that we have today. So we will get there. I think it's unavoidable, and it takes big entities like China, US, and others that are putting a lot of resources into the US. Instead of competing, why don't we do something to help the species?
Right. Daphne, I don't know if you have a comment to follow Eric as well on that subject.
No, I completely agree with everything that Eric said, and I want to highlight a somewhat different angle on the issue of data availability and data quality. And I'd like to call into the spotlight one of, to my mind, the biggest enabling data sets that have been created in the last decade or so, which is the UK Biobank, which admittedly has the limitation that Eric said it is predominantly European ancestry. So clearly imperfect in that way as well as others, but it has so many advantages in terms of very careful curation, incredibly deep phenotyping, the multiple layers that Eric talked about, allowing us to really understand the connection between genetics, between molecular characteristics of the people involved in the clinical outcomes, including more and more so longitudinal outcomes as the data from the National Health Service is being layered on top of the deep phenotyping data. I think a few more repositories of that kind, which do require a concerted effort and a lot of thought being put into how the data can be collected and how it can be shared broadly, I think is absolutely critical, because one of the big successes of that repository is both the quality and rigor, but also the fact that anyone who's a verified researcher can have access to it. And there's like half a dozen papers every month or more, which really elucidate mechanisms of diseases that we haven't previously understood. So a few more high quality repositories like that, I think, can be transformative to how we understand and tackle challenging health problems.
Certainly. And you speak to the point of one is to get to a point where you have a large amount of data, but how do you establish standards to make sure all that data is consistent and therefore not used in a, if you will, dangerous way? But if you guys will allow me, there's one recurrent question that's coming up on the chat from the audience, which is for both of you. How do you keep up to date with the sheer amount of technology and information that's coming with your busy lives? What tools do you use? What suggestions do you have? It's now the 6th time I'm seeing the question. Actually, somebody else just posted it. So,
Eric, do you want to start?
No,
you, Daphne.
Boy, it's indeed a challenge, and it's there's just so much of it. I mean, just if you're tracking COVID-19, of course, that's an extreme outlier in that regard, but there's, dozens of papers, maybe hundreds of papers I've lost track every week. And many of them are published on unrefereed venues as preprints, which is wonderful from an access perspective, but it makes it hard to judge the quality without a proper peer review process. And frankly, some of the ones that have been peer reviewed, maybe because of the speed and urgency, haven't panned out as well as one would hope in terms of the rigor of the process. So I wish I had a really good answer rather than just exacerbate, amplify the question. I think there's, one can count sometimes on one's peer network in terms of bringing to your attention papers that are particularly interesting. I think there are some journalistic sources that are doing, I think, a better job than others at unearthing and highlighting papers that are of particular interest. So I track a number of those. But yeah, you oftentimes discover that there are papers that were pretty important and you missed. One of the things that I think is useful for us as researchers is to really clarify what our personal focus is, and really come up with ways of tracking literature that's relevant to the problems that we're trying to solve, recognizing that as the breadth of science becomes so much larger and there's so many people that we don't know that are contributing to it, we're not going to be able to follow everything. So can we at least follow stuff that's directly relevant to our work? I don't know. Not a great answer, but the best I have.
I actually agree. The focus part is really my love of in recent years has been AI in medicine. And that's why Pranav and I started that Dr. Penguin. And we put that out every week, and we try to find all the AI in medicine and life science papers so that everybody at least will know them. But it's been really challenging. I'm an information junkie to be able to track the COVID-19. I find it a challenge it's kind of fun because there's just so much data coming in every which way. I use Twitter as a great tool to see the things that I might not have seen from the other people who are really tracking the pandemic from every respect. From the different whether it's at the molecular level or at the patient care level or whatever. So it's a challenge, but it's actually I think it's one we can all rise to. But as Daphne points out, you can't do it for all areas. You got to just pick the area that you're into. And if you can master that and stay on top of that, you're doing really well.
Certainly. Eric, as you spoke about Dr. Penguin, I'm sure some folks may be wondering why you called it Dr. Penguin. Not to spend a lot of time on that, but.
Well, I give credit to Pranav because he came up with that name and I wasn't going to challenge him. And, it's just kind of just something odd enough that people wouldn't forget, but they always ask, where did it come from? So, I'm really worried because I don't know what I'm going to do without Pranav because, we work on that every weekend. We come together to pool our papers that we found, and then he does a quick summary, and I couldn't do it without him. So Dr. Penguin's, half-life could be limited with him getting a PhD and going on to faculty. I don't know what I'm going to do, but hopefully he'll stay with it.
Hopefully the Penguin keeps going. Going to shift gears a little bit again. And again, this is building a bit upon the theme of some of the questions that are recurring on the chat. But just again, drawing from your talk, Eric, you talked about before we get to precision medicine, we need accurate medicine. Right. And obviously, as you and Daphne know, one of the things that we focus on is data, but the other side of it is getting good ground truth. A lot of studies show, and sometimes we have the human experts as the ground truth, but we know that there's a lot of inter and intra-observer variability. So if we are going to move towards precision medicine, should we now establish stronger standards for ground truth and say we should work towards surgery and pathology as our ground truth where possible?
Well, I think the problem with the ground truth, it sounds like it's super truth, it sounds like it's the ultimate. Say, wow, that's the ground truth. Well, it turns out it's maybe not always, often not the case. Oftentimes what's used to establish ground truth is, a very limited number of clinicians, physicians, whatever. So we ought to do better on that because that is, of course, critical to the success performance of the model. But you're bringing up an important thing. Precision medicine as a term is a really bad term. It was kind of adopted by the National Academy of Medicine. And, just because you can do the same mistake over and over again reliably, that's not good.
Right.
And if we have supervised learning with ground truths, but they're not really well called, we got a problem. And then what about when we go to self-supervised and unsupervised learning? Where do we go with that, where there is no anchoring? So these are really important points that you're bringing up that we have to pay considerable attention to.
So one thing I'd like to add to that, which is one of my favorite papers that was one of the last that I wrote before I left Stanford and is in some ways the precursor to some of the pathology work that you talked about, Eric, was a paper that I wrote with my PhD student at the time, Andy Beck. And that was one of the first applications of machine learning to digital pathology. And what we did in that paper was we used patient clinical outcomes rather than pathologist labels as ground truth. So we used 5-year survival data. And the truth is, if we hadn't done that, the paper would not have made the discoveries that it did because it would have been limited by whatever it was that pathologists were annotating on those images, which frankly turned out to be suboptimal. And one of the major findings of that paper, which I'm still very proud of today, is that it was one of the first to identify the significance because it basically used a very unbiased approach and trained to 5-year survival, which is a form of ground truth, confounded though it could be in some ways. It discovered the significance of the architecture of the tumor microenvironment as being one of the most significant prognostic factors for cancer survival. And to me, that's a great point of pride because if we had been labeling our data using the pathologist annotations, we would never have uncovered that particular aspect because pathologists at the time were only looking at characteristics of the tumor cells.
Yeah, no, it's a great example. Yeah, you can't emphasize this stuff enough. I'm really glad that question was brought up.
I suppose stepping back a bit, instead of just ground truth, what is acceptable performance? And instead of how should we be benchmarking our AI model performances given the human performance variability? What would the ideal look like?
Well, just to mention, there is a series of papers coming out soon from the Consort AI. So you may recall that it took almost 15, 20 years before there was a consort to give the characteristics and features of what performance and publications should be like. And now we're having that very quickly for AI. So there's going to be now standards. I think that's going to be important. But one of the things that I really note is that performance of models, when they're done in silico, retrospective, is really not something you want to rely on. That's why these prospective studies are so important. Almost every time there's been a prospective study, like diabetic retinopathy and several other examples, it hasn't performed nearly as well. It often well, but not nearly as well as the pristine in silico story. So we got to keep that in mind when we try to extrapolate from retrospective data sets. Daphne?
Yeah, no, so to add on top of that, because this is a question that I think about a lot, is also the need to really test the algorithm with the kind of challenging scenarios that it would encounter in real life. And the prospective versus retrospective is one important instance of that. But also there's the question of, if you're looking to build, for instance, an AI system for radiology or pathology that would be used across multiple hospitals, not just in the one that you trained it on, then you want to make sure that you test it in a way that cross-validates across hospitals, so that you train on the data from some hospitals and test it on other hospitals. Because otherwise we find that AI systems are incredibly good at overfitting to things that could well be artifacts, or maybe sometimes these are aspects of the patient population. Sometimes these are really downright artifacts. And there was a beautiful paper, I don't know if it's been published since, because it was in bioRxiv when I looked at it about a year ago, where they found that a machine learning, deep learning system was doing a spectacular job at labeling fracture images, X-ray images as fracture versus non-fracture. And when they figured out why, it turned out that it was because they were identifying aspects of the specific scanner that took the scan. And once you kind of eliminated that covariate and corrected for that, it was getting performance that was only slightly better than random.
Sure.
And so I think that is a very serious issue. You could easily imagine the same thing happening in, cancer radiology, where tertiary care centers have a different type of scanner than primary care centers, and all of a sudden you get really good at labeling cancer without actually looking anywhere near where the cancer is. So it's really important, I think, to subject the system to a level of rigorous testing that is much more aligned with how it would be used in real life.
And I think both of you were touching on this, the in vitro or in academia, maybe in the lab setting versus in industry. And I think both of you have seen both sides. How do you see each of these settings driving the initiatives you want to see? And how is it very different?
I find that today, and I wish it were not the case, and it maybe will change, but it's just a lot easier to get the kind of resources that one needs on the industry side, whether it's the simple, more obvious things like financial resources. There's a lot of capital right now in the ecosystem, and a lot of it's relatively easy to get funding for good ideas. But it's not just money; it's also the ability to hire people who are interested in actually building things rather than writing a paper and moving on to their next postdoc or whatever. It's the access to data where there's often a mismatch of incentives between, for instance, the repositories where the data exists and the need of an academic institution to publish, which might not be something that whoever has the data is excited about. So there's a lot of ways in which And even some simple things as access to cloud resources is not something that every academic institution has fully mastered. So there's a lot of things that make it easier at this point to do the kind of at-scale research that one needs in an industry setting.
Yeah, I mean, I think they're complementary, obviously. When you have in the life science industry, it's going to be a project specific, to make a difference. That's going to, sure, it's going to help patients, but it also has to help the investors. On the other hand, in the academic world, you've got the chance to be more theoretical and don't have to be burdened, and you can have a more range of motion because you're not on a particular product development path. So, I mean, ideally, what I don't get is the fact that we are spending trillions of dollars to rescue this pandemic, or all of a sudden this money has appeared and it's been giving out to all sorts of strange, unknown entities. But we haven't had the money to support research in this country. And that's why so many people have resorted, because as Daphne's mentioned, you can't get the resources. And if you want to get them, it may take years to get them, and you may never make it to that point. So you take a position in industry, and no one could ever fault that, because we are resource poor. And it's just amazing. We have an NIH budget of $35 billion, and we've already put out $3 trillion for unknown purposes. I mean, anyway. Don't get me started.
No, well, the one thing I will say, Eric, that I see as a very thin silver lining on this pandemic, which I hope turns out to be the case, is that people might realize that if we do find a vaccine for this pandemic within less than a year, that people will realize that this was only possible because it was standing on decades worth of basic science that was done in academia and industry, and that we really need to have much more systematic and extensive support for the basic science that will help us deal with the next crisis, whatever that is, whether it's a pandemic or climate change or something else. We need to continue supporting basic science because it's absolutely critical to our future.
Eric and Daphne, that's great. I'm sorry to cut you guys off. I wish we could keep going because this is amazing. On behalf of everyone, we want to thank you for this amazing discussion. Wish we could keep going. You should see the chat. It's blowing up. So I want to thank you both. I want to thank my co-moderator, Sharon.
Thank you.